Thank you. So I've, been asked to come and talk to you, really to plug a trial that we're about to start, and I'd love to hear what you think about it. Before I get going, can I just respond to one of the things from the last, which was about the BRAF status in stage 3 disease. So we're all testing for it because there's now national guidelines that we should do. We're probably not feeding back to everybody about the result, but that's also because we probably check again if you develop further disease because the BRAF status can change. So, yeah, absolutely, people should go and ask what their result is, but it's an evolving field. Anyway, standing up here gives me an opportunity to say thank you to a few people before I get going, because you always forget at the end. There are people here in the audience that I'm very indebted to, and some of them that aren't in the audience. So Mark Middleton is the reason that I'm really stood here, being a medical oncologist treating melanoma. Paul Lorigan's also somewhere in the audience and taught me most of what I know. And Pippa Corrie, who's around, has been a huge support to me. But I also get to thank other people on this occasion, because I'm not just talking to clinicians. So I've got a fan group at the front here, and I'm not trying to name and shame or anything, but certainly South Yorkshire has always been really, really good, I believe, at getting patient and public involvement in our research and our work, and John Rouse and Jane and Simon, who's around as well, Simon Rodwell as well, have all been absolutely instrumental in moving forward our work, and I thank you, and I will be asking you to do more in the future. I'll start my bit now, if I can get this to work. So I know that James Larkin will have given you a really good overview of immunotherapy in cancer. I'm just going to quickly talk about that as the trial that I'm going to talk to you about is based on immunotherapy. So if you go online, this is the kind of things that you see about immunotherapy. So it's all about the fight. We are going to repel the cancer, and we're going to beat up the cancer. We're going to fight the cancer in our battles. And it's a revolution. And this is all true, and I'm there with you. But this one, I couldn't believe. Okay, this one is not true. At the moment, we do not have immunotherapy that fights disease without side effects. Okay, please find that immunotherapy, and that will be great. But we aren't yet at that point in time, as you've heard already. So the rationale is that it doesn't make sense to just give a toxic drug to a patient and hope that kills the cancer and doesn't have any bad effects. So that's the rationale for chemotherapy. But immunotherapy makes much more sense. Switch on the immune system, keep the immune system switched on, and let it do the work. And we base that on anecdotal evidence. Sometimes melanomas and other cancers can spontaneously regress. Often the body is trying to get rid of the cancer, so the cancers are surrounded by inflammatory cells. We've seen examples of autoimmune disease that have coexisted with tumours as well, and so it does look as if there is a link between those side of things, especially for cancers like melanoma and small cell lung cancer. And there are various immunotherapies around. I'm going to focus on the monoclonal antibodies, but in the past we've used things like interleukin-2, cancer vaccines, and T-cell therapy, all of which are going to be mentioned as well today. So I came into melanoma treatment at the right time, I think. So I became a consultant in 2006 when we were really doing the research that led to all these changes. And I'm so glad that I was able to be there at that point in time, because, to be honest, before we didn't really have many treatment options at all. Dacarbazine chemotherapy have very poor response rates. I trained at the Christie, so I did give a fair amount of high-dose interleukin-2, or was supervised doing that. But then, of course, we got the newer drugs that have good effects, and that's just been wonderful to see. I'm not going to go into detail about this. I'm quite a simple medical oncologist, and this is a bit scary for me. But basically, this is just saying we've got 3 classes of these types of drugs. They act at different points along the T-cell pathway. So ipilimumab acts at this part. The PD-1 and PD-L1 inhibitors act at that part. they all have possible side effects. It looks like the PD-1 and PD-L1 inhibitors have less side effects than the ipilimumab. So, focusing now on the PD-1 inhibitors, so the main ones at the moment being pembrolizumab and nivolumab. So these are clever drugs. They're highly selective against the PD-1 molecule. And what does it mean in reality when we say you're having a PD-1 inhibitor? Well, you're going to have an intravenous strip every 2 or every 3 weeks, depending on if you're having the nivolumab or the pembrolizumab, and you're going to have that until progression. And these are not cheap drugs, and thankfully we don't have to think too much about that side of things as prescribing clinicians. And NICE has agreed that we can give these drugs to people. So why are we giving these drugs? Well, as I said before, dacarbazine didn't really give us much at all, unfortunately, although it did work well in occasional people, which is why we kept doing it, and I still have some of those on the books that have had their 6 courses of dacarbazine and are still doing extremely well. But we want more people to do well, of course. So what these curves are showing what we're aiming for, which is this long-term plateau, this survival plateau. And this green one is the one that you get with ipilimumab, and it looks as if not only do the PD-1 inhibitors give you better response rates, but it also looks as if they've got the plateau as well. So that's great. That's what we want. We want to be seeing patients for years and years. But possible side effects. So we've really all had to learn a lot about these, and it started off with just the melanoma doctors having this specialist knowledge. But now we're giving these types of drugs to pretty much everything. So I treat lung cancer as well. So I've got really, really busy recently because of giving so many of my patients these immunotherapy drugs. But basically, the side effects can affect pretty much any part of the body, unfortunately. So most patients have a rash, not usually as bad as this blistering rash, but that's the kind of thing that can develop. Pneumonitis, so inflammation of the lungs, can be really serious. So I've got a patient who's just been on intensive care with severe pneumonitis, thankfully has now just left intensive care. And with the ipilimumab, we often saw very severe inflammation of the colon as well, giving profuse diarrhea. So this is all much more swollen than it should be. But what we often do, because we know to monitor people closely, is we pick things up before they become a clinical problem. So these are a normal liver test, and then suddenly it shot up before the patient became symptomatic. We were able to treat with steroids, and it came down very quickly. And the other thing about these side effects is with chemotherapy, you used to get the side effect, and you knew you had this kind of 2 or 3 weeks where you had to get the patient through it and support them through it, but then that would be the end of it. But that's not the case, because you switched on the immune system, which, as I said at the beginning, is a good thing to do. But it can be a bad thing to do if you're trying to deal with the side effects. So thankfully, all the side effects don't tend to come at once. I think that's good. However, it seems to be in some patients that you get one, and then another, and then another, and then another. And down here are endocrine problems and neurological problems. And so it can really be a case of, as I say, careful monitoring and trying to get people through this. And I come back to the costs, which are not the main thing, but which have to feed into everything that we do. So we've always given up to 4 doses of the ipilimumab, and that was about £80,000. The pembrolizumab, if we give it up to 2 years, which we can do, is just under 200k, and you can see nivolumab is in the same ballpark as well. So these are very expensive things to do, and that's just drug costs, and drug costs change, and drug costs are, the companies obviously want to make themselves more adaptable, so that more of us can prescribe these things. But these are significant burdens, of course, on the NHS. And you haven't even added in the outpatient appointment cost and the chair time for having the administration and the inpatient beds and the supported measures. So if you get that colitis I showed you, you may need 3 doses of infliximab to try and reverse that, and that's just under £1,000, £2,500 for those treatments. And of course, we're going to keep spending that money. We're going to keep trying to get the patients through these things. I'm not going to go into this in detail because you already heard this from Nick, who must be congratulated because it's really hard to talk to someone else's slides. But just to say that, of course, combination ipilimumab and nivolumab is a really, really interesting area at the moment. And we are treating some people with this. And we don't have an upper age limit. I think it sounded a little bit like that may be the case. But we do choose our patients very carefully who get this. They need to be able to cope with the side effects, which grade 3 and 4 toxicity with the combination means that 55%, 56% of your patients end up in hospital as a result of the side effects. But coming back to why we do it again is the fact that even patients that stop these treatments because of toxicity, a lot of them, so 69%, got good responses to the treatment. So immunotherapy really is something to consider in every case. So as is often the case when we start with something and we get good results, we then create lots and lots of questions, and that's great for a researcher. But we need to get the answers to these things as quickly as possible so that we're thinking about the right people to give these drugs to. So we've touched on the fact that who should we be giving these drugs to? Well, you think it would be easy. You think it would be whether you'd got the right molecule there to be targeted, but it doesn't seem as simple as that. It seems more clear-cut in lung cancer, so we do use levels for lung cancer, but not for melanoma at the moment. And then there are other things that may help us decide which patients to treat, so tumour mutational burden, microsatellite instability. These are the kinds of things that are being looked at in clinical trials at the moment. What I'm going to talk about in a few minutes is how long we should give the drugs for. So that's the trial that I'm here to talk about. Other questions are, can we give a flat dose? So it does look as if we could probably give the same dose to everybody of these drugs, which would be a cheaper way of doing it, because if you're just giving one vial rather than breaking over several vials and pharmacists having to think about what they're doing, then this will be an easier way to do it. And we've already mentioned what should we be giving with these drugs to make them better. I suspect in the future we'll look back and say, we gave ipilimumab and nivolumab, but gosh, wasn't that hard work, and some people do really well on it, but it was a very intensive time. And we're thinking about combining it with other things such as radiotherapy as well. So James may have mentioned the PERM trial to you this morning. And then we have to think about what we do. Although we do get good responses with these drugs, they don't always last indefinitely, and they don't always work at all in the first place. So what should we use in those cases? Would another PD-1 drug work? Should we try ipilimumab? All of these types of things. Obviously, we've got BRAF inhibitors in some cases as well. And then other better drugs. So that's already been touched on as well, and I'm sure there are better drugs out there that we will eventually start using. So moving on to the Dante trial now, which is a new study looking at the duration. Now, we can't look at every single different duration, so what this study is looking at is whether you can stop your PD-1 treatment, your pembrolizumab or your nivolumab after a year of treatment, or whether you should carry on until progression. And a lot of people have been involved in getting us to this stage. I certainly haven't done this on my own, but lots of clinicians, so Ruth Plummer from Newcastle, Christian from Southampton, Pippa is here from Cambridge, Ferdy is a radiologist from Cambridge, Jane is a clinician from Leeds. There are lots of people here who give additional expertise, so statistician, health economist, quality of life. And Simon, I can see you now. You're on here as well. So the background for the trial is that even if someone's got a BRAF-positive tumour, we're often still giving immunotherapy as the first-line treatment because we're aiming for that survival plateau. And as I've said, these are drugs that we need to give every 2 or 3 weeks for a long time. But what we all know as clinicians treating with these drugs is that most of the responses seem to occur in the first year of treatment. And what we also know is that even when we stop the drugs because of side effects, the responses can often continue. So you may have seen some of these types of graphs this morning. So I like these. I can get my head around these ones. So every line is a patient. Patients on treatment are in blue. When you've stopped, you go red. This is the time along the bottom. And these circles are when patients responded. So you can see, if that's going up to a year, you can see most of these responses are occurring in the first 6 months. So I'm just going to give an example of one of my patients who I actually treated with ipilimumab, and really what we're trying to achieve and what we can achieve. So this gentleman came to me when he was 49 years old in 2011, and he presented with brain and lung metastases. So a really serious situation. And we were testing for BRAF then, but his BRAF status was wild type, so we didn't have a treatment option from that point of view. He had surgical excision of brain metastases. We do have Gamma Knife in Sheffield as well, as was mentioned, followed by post-operative whole brain radiotherapy. And then he commenced temozolomide, which is the tablet version of dacarbazine, which is supposed to have better penetration into the brain, but unfortunately it didn't help in his case. And then we were able to get him some ipilimumab on an expanded access program. And we were just kind of getting used to giving that and getting used to the side effects that came with it. And he got this terrible diarrhea. He had to stop. We gave him steroids. We gave him infliximab, which did everything we could to try and reverse it. And then we didn't have anything else that we could give him because we didn't have the PD-1 agents then. But I'm pleased to say that actually he didn't need anything else. So this is his chest. So this was his lung metastases at the beginning, and they shrunk away. That seems to be scarring. This was his biggest brain problem, and that shrunk away. And he just kept coming back to clinic. And he developed this white forelock, which was his autoimmune reminder. And he loves that because that shows that the drug's still in. He's still got his white forelock. He eventually stopped having scans because they weren't giving us any more information. He got his driving licence back, and he comes to see me every 4 months, and he's doing really well. And of course, that's what we want to be doing time and time again. So, what we're doing is looking at opening Dante in 45 UK sites. We're going with the Avast-M sites in the first instance, but it can be opened up to other sites as well. So we need sites that are giving PD-1 agents that are used to pembrolizumab and nivolumab. We obviously want to give it to patients with advanced melanoma, so we're going within the licensed indications, and they can have had previous BRAF treatment. We always try to do trials in 16 and above, but it's got to be 18 in this trial because that's the license. And what we're looking at is that patients at 1 year are free of progression, have a good performance status, don't have symptomatic brain metastases, and don't have significant other illnesses. And our main aim is to look at progression-free survival and see how this compares between the two arms. But we'll also be assessing all these other things that I've mentioned as well: quality of life, tumour response, toxicities, costs, and looking at whether patients actually want to take part in this and their decisions for doing so or not. Sorry, this is a bit busy, but I've covered most of it. So we're going to identify patients and talk to them and register them between starting treatment and 12 months of treatment. And then at 12 months, we're looking for 534 patients in each arm, and we're going to either continue treatment until progression or stop. And then monitor both arms in the same way with our usual standard of care of looking at toxicity, looking at scans, looking at health economics and quality of life. And then they'll be followed up for an additional 4 years after that, which is standard as well. So we feel this is a trial that's probably unique to the UK. It was developed by the NCRI Skin Cancer Group. It's been funded by the NIHR. And we have spoken to the drug companies as well. Obviously, they're interested in the results of this. It's going through the regulatory processes. Trial publicity, including this, have begun. We'll be going to sites shortly, so most sites know about this already, but we'll be getting their ideas about how many people they think they can recruit. And we're planning to open in February 2018. And Pippa Corrie is leading on the funding application for translational studies. So this is my last slide to say thank you. I hope you'll be able to disseminate the information about this trial as well. We are going to be doing some focus groups in the next few months so that we can talk about the best ways to talk about this with patients and how we think patients will get on with this particular trial. So if you are able to help with that, please do email here. It would be great to hear your thoughts on that. And I'm happy to take any questions. Thank you.
I'm just going to jump up. Neil, Stephen, up, there we are. Magic slides over there. Thank you. Got time for 2 questions and then we're doing Nick.
It's coming.
Hi, sir. I just wanted to ask, for the patients who are randomised to the arm where they stop after a year, is there potential for them to re-challenge if they have progression?
Yeah, so that was our first question as well as patients, and so we spent a lot of time trying to sort that out. And so NHS England have agreed that we can restart that drug. We may not want to. We may think, okay, we've got a trial with a good drug, or we've got another thing that's come through by then that we want to try. But yes, we're not taking that option away.
Mine is more of a general question regarding clinical trials. What benchmark do you set in terms of what progression patients are making and whether that trial is a success or has not been as successful as you would hope it to be?
So we use standardised scans on each patient to see how much the disease has shrunk or grown, and in using those percentages we then decide, and it's quite broad, so it's not that you've just had a slightly different slice and actually you're getting a slightly different view. So everyone uses standardised readings of response and progression and stable disease. Sorry, so that was your first question, and then the second one's gone out.
It was in terms of if the trial is
a success,
as near as the outcome is not as you would expect it to be.
Yeah. So every trial at the beginning, you have to define what you're looking for in terms of how many patients you need, how much of an increase in progression-free survival you're looking for, or in this case, what we're looking for is that we're not getting worse progression-free survival. This is a large study. We're not just going to start and then continue regardless. We're going to keep reassessing. There are 4 planned analyses in there for us to look at if patients are taking part in this, and also the results that are coming through as well. So every trial is different. Some trials you're looking at a lot of the toxicity, the safety data. This we think we know already what kind of side effects we're going to be getting, so we're going to be looking at whether we're doing people a disservice by taking them off the treatment. So yeah, it takes. This is why I need the statistician. This is too clever. But yeah, that's a really important question. Thank you.
Thank you very much.
Okay, thanks.